Good evening, everyone. Good evening, one and all. On behalf of BSc Bharat and Medicine, I, Satul Kavi, extend a warm welcome to our distinguished speaker, Dr. Leela Vaishman, and all our valued guests joining us for this webinar on intrapartum care for joyful mother. We are really excited to have you, ma'am, to share your expertise on intrapartum care, and I'm sure with that, I would like to take this up. Yeah, that's it. I will take this opportunity. So, Dr. Ma'am Leela Vais, ma'am, is a professional position. She was a former senior professor and unit head, IVF consultant, and member of Research Review Board, SMS Medical College, Jaipur, and senior consultant at Cocoon Hospital at Jaipur, and senior consultant at Assad. And Gynae Society 2013 to 2015, and Secretary Jaipur OBS and Gynae Society 2005 to 2007. And there are many more about from these. So we have just highlighted few. I would request Madam to take over the session from here onwards. Thank you.
Just to hold on, Prasad. At audience level, we could not able to hear.
Yes, at the outset, thank you very much to BSc. One thing is I'm actually happy to do this webinar. The reason being, many of the pharma they are talking about the normal and labor, and that too with the vaginal delivery. Uh, we all are checked by that the cesarean rate is increasing, and definitely the number of cesarean is increased in last few years. So, to create awareness regarding the vaginal birth. So, now we have stopped telling that it is a normal delivery or it is a cesarean delivery. We just say that it is a vaginal birth or another is the abdominal or the cesarean birth, we call it as. So, just say the normal delivery and that. So, if we are able to make this vaginal birth more comfortable for our patients because they are mainly these our females are very much scared of the vaginal birth, and the reason being they say I can't bear this pain. And usually what happens in all of the gynecologists, our friends, those who are attending this, they everyone has this experience that patient silently comes to you and they say, "It's just to ask my mother or mother-in-law they should go out. I have to talk to you regarding two things." And the first thing is that, doctor, I can't give these pains. So you make any of the indication in front of my parents or my family that the cesarean can be done. And some patients they are very bold in front of every family member. They say, no, no, no. I don't want a normal delivery. I'll go for the cesarean. So this is the one of the big problem with the obstetrician because on one side that we have to listen our patients because the patient's view is very important regarding their mode of birth. So mode of delivery again it becomes a very important part for them. But to eradicate this fear of the vaginal delivery, that is the birth if we just removed from our patients and even from our doctors, because so many of the young doctors, the obstetrician, they don't want to do the obstetric practice just because of that. How to go with the vaginal delivery? If anything happens, then more and more litigation we have to face and all these things. So really, thank you, BSV. And Mr. Shantu, when you asked me that we have to do on this labor, definitely I am very happy to do these webinars. So at least if we can motivate our doctors regarding this, definitely then the message will go to our public also. So this interpartum care for joyful motherhood, that is definitely very good title you have given. This process is not very early. You have just mentioned in my CV that I was secretary in 2005 to 2007. That was a time when Foxy also actively promoting this active labor, means active management of labor. Now we are concentrating only on the active management of third. Or Driscoll and his colleagues reported that advantage of active management of labor, resulting in the shorter labors, improved obstetric outcomes, and lowered cesarean section rate. Yes, definitely, if patient is under, means though there are few indications which we know that is required, that is, you can't avoid cesarean in these cases, then you have to do. But there are few indications where you need means even the patient coming in the early labor, and once they come in the early labor, they say, no, I can't bear pain, you just do my cesarean. So we can counsel them. And accordingly, we can tell that we will support your labor, we will fasten somehow. Otherwise, this injudicious use of any of the drug is prohibited in obstetrics. So judicially, if we are doing this, then this is some modified partogram. Partogram is the most important thing, which is forced by everyone. Means, as I mentioned, that there is a government program which is going on, the Laksh program. In this, all nursing staff has been trained how to draw your partogram during this. This gives a progress of labor. And even on one of the program which is run by the Foxy, we do in Manyata, that is also this partogram has been taught this. And all our learned colleagues, those who are attending this, they all know the partogram is how important. You can detect where is the labor is going in is slower, or when you have to intervene, and how to this accelerate this labor, and how to notify that every steps, that even pulse, BP, fetal heart, number of contractions, and dilatation of this. So, because there is, means even in the oxytocin, you all must not be knowing that in the government sector, now this has been controlled. Means oxytocin is for the active management of the third stage of labor. You can't use without any indication in the intrapartum period. So induction is to be, yes, definitely to be when it is indicated, that should be done. So the patient selection for your, either you call it as a program labor or the active management of labor. So there should not be no identifiable medical or obstetric complication to be there. And usually we select either the primary gravida with the singleton pregnancy, cephalic presentations, and these are the patients where these patients to be if going on the spontaneous labor. These are the right candidate for the acceleration of this labor and the programmed labor in these patients. Even in, and definitely it should not be preterm, because 37 weeks has been taken as a term baby. But if you are going to induce, definitely it is at the 39th week if other indications are not there. Then, and we are not going, yes, post-dated we usually avoid in Indian scenario, because in Asians the maturity occurs earlier. So we are not very much of pushing our patient toward the postnatal. Then the admission NST should be reactive. That means the fetal heart should be there. It should be a good and reactive fetal heart you are needed. Active phase of labor with the cervical dilatation 4 centimeters and 50% decreased. So that's why once the patient has entered into the active phase, means we take it as a up to 4 centimeter. This has been taken as a latent phase and after 4 centimeters. And there are some fight between the different countries. Like America, they say it should be a 6 centimeter, but not in India. And even in the WHO, they take it as a 4 centimeter as an active phase of the labor. So these are the prerequisites required. Then only you proceed with the active management of your labor. Maybe a primary or multipara, yes, more than 30 weeks, low risk patient should be there. Presence of anesthetist and neonatologist that will be required every right. So that's why the obstetric unit, which is fulfilled with their presence of full-time anesthesiologist, full-time neonatologist, then you feel safe, and patient also feels safe that every department is working actively and they are supporting, because as and when you require, because anesthetist is also required. Sometimes when I'll just come forward that in the this planned labor or the active management, we need sometimes anesthetist also. And if any time emergency cesarean required, they should be readily available for us. A neonatologist, all we know that once the baby delivered, that should be taken care by the neonatologist. Yes, the consent, which is always very important, which we have to take. And patient should be in the active phase of their labor. Not to be considered intrapartum care means high risk and all other complicated patients. We should not malpresentation, encephalopelvic disproportions, pre-labor rupture of the membranes. Yes, we avoid, but sometimes we augment and also plan that if everything is normal, NST is good, liquor is clear, we can go with this. So these contraindications should be in your mind. We should not proceed with these patients. But yes, the normal, all patients can be taken. So the medication protocol for the intrapartum can bring only after the patient enters into the active phase. So we should not start with that. One term is that induction of labor is totally a different thing, where the cervical dilatation has not started, patient has not gone into the labor, but we have to deliver. And that too induction you will do after taking all consideration of the Bishop's. So if we are going with this programmed or active management of the labor, the starting point of the active phase of the labor is identified on the basis of the clinical evaluation, and the following parameters are to be satisfied. That is cervical dilatation 3 centimeter or more, so approaching 4 centimeter. Effacement should be more than 50%. Uterine contraction, we call it as the moderate uterine contraction, that is 3 contractions within the 10 minutes. And that should be lasting for 35 to 40 seconds. And head should be engaged, and there should be no clinical suspicion of CPD. So a good means the pelvic assessment to be done by an obstetrician. So they rule out that there is no CPD, cephalopelvic disproportion should not be there, and patient may have show or the this draining. It's definitely that with the cervical dilatation and all these are there. So medication used in the intrapartum care are, as per protocol, if you go with, combination of drugs are used in provide the effective pain relief. Because initially I told you that we have to counsel our patient, yes, we are taking care of your pain. But definitely without contraction or without pain, the patient can't deliver. She has to also add on her force, that is the the pressure which they have, pushing force they will require at the time of the delivery. But initially pain, and that pain can be minimized by the drugs, and the drugs which are used, which are not harming to you and your fetus. So this coupled with the antispasmodic drugs, which helps into the cervical softening and yielding a dilatation of the moderate driving force should be created by these drugs. Then advantage of protocol, what happens? That provides with the benefits of the drug synergism, while at the same time the restricting the doses of the drugs to minimize the amount commensurate and achieving the progressive labor, while at the same time safeguarding the mother and her fetus against any major drug adverse effects. So these are to be fixed, that we can't use any of the drug anytime. So intrapartum care protocol, if continue, that start in the intravenous infusion line with the 5% regalectin. If patient is going in spontaneous in very good labor, there is no need of putting this intravenous line. It is advised by the WHO, but in majority of cases, if you go with the private or the government setup, they always put a line, intravenous line, because you need anytime anything. So for the safety of the patients, everyone is putting this. And then ensure that the pains are optimal, that is 3 to 4 sustained pains within 10 minutes. If necessary, you may add 2 units of oxytocin to the drip to give it, or tablet Primoprost, but usually we go with the oxytocin, which is very safe. Is this Primoprost is, some doctors, they are not preferring the drugs due to the fear of this fetal distress. Then this part was that augmentation. Means if the contractions are not adequate, then you have to give the some of the utrotonics. This, then you can, the pain part, how to control that pain or minimize the pain. You can dilute an ampule of 30 milligram pentazocine or the fortwin with the diluent like the normal saline or the distilled water, and similarly dilute an ampule of diazepam, that is 10 ml to dilute. The dose, which means this solution, 10 ml solution has been made, and administer 1/5, means 2 ml to be administered, that is the 6 milligram of pentazocine, 2 milligram of diazepam, slowly in the bolus from that which IV line you have put, you can give on this. So starting an intravenous infusion line with the 5% lingual rectate, that we give around 20 drops per minute. That ensure that the pains are optimal. So there should not be hyper contraction, hyperstimulation should not be there. So you have to maintain these pains should be not more than 3 to 4 per 10 minutes. And that should not be, again, that you have to say means 3 or 4, but it should not be lasting more than that. And there should be an in-between relaxation time should be there. Otherwise, these tonic contraction will create a fetal distress. Then this oxytocin and all obstetricians, they know how to monitor and how to just maintain to the moderate uterine contractions combination. Then you dilute an ampule of 30 milligram pentazocine or fortwin with the diluted saline, and all similarly that diazepam which has been given, and slowly the bolus from through the tubing of the infusion, which again the 1/5 this. Then we have to observe the progress of the labor by charting the maternal and fetal parameters every hour or the earlier if indicated. Means that's why the partogram is necessary. If you are going with this, you can put all these parameters over there. Then assess the progress of labor on the basis of cervical dilatation and descent of the head, and as documented periodically on partogram. So definitely the PA examination is required, how much of the head is descending. And yes, the cervical dilatation only you can assess by the PV examination. But if you have a good center, you have a good, means sonography machine is over there, the transpiration sonography, by that the dilatation can be seen. When the patient is in advanced labor and the fetal head pressing down on the pelvic floor, the patient starts complaining of the severe pain or the bearing down sensation. At this time, the cervix is often about 7 to 8 centimeter down. And this is the time the administration of the injection ketamine if required. If patient is not able to bear these pains, then you can add on the ketamine can be given. So the anesthesia during labor, the proven obstetric anesthesia is the epidural anesthesia. We all know that can be given. So in place where the epidural anesthesia cannot be provided, tramadol, a centrally acting non-opioid analgesic, has been used as a labor analgesic. Ketamine, a dissociative anesthetic, is gaining popularity as it provides the excellent pain relief and the patient satisfaction. Because for this epidural, you need an anesthetics. But in a small nursing homes where the anesthetics are coming on call, yes, definitely they are reaching within the 10 to 15 minutes once you have decided any cesarean. But they are, if they are not for the 24 hours, then the choice of this alternative choice, that is, you can give the tramadol or you can give the ketamine. Yes, for the ketamine, you don't require any anesthetics if the properly observed patient by the obstetrician. So level of the analgesia assessed using following scale. 0 means no pain. First is the mild pain relief. 2 is the moderate pain relief. And 3 is the excellent pain relief. So you try to see that by giving whether it is, there is a some pain relief or there is even no pain relief. Some of the patients, those who are very anxious, they will say, you put anything, they will say, no, I will not relieved with the pain. So there are various clinical evidences which say that if you use these method of active management of labor, the vaginal delivery rate is around 88% in these cases. Study group and in control group was 81%. So this spontaneous unassisted delivery was 121. There's this low forceps required in less number of the patient. Ventouse again, it was used in that because we are more on that. Because once sometimes the ventouse we use when patient is not able to push and all say because it is one of the safe instrument. But yes, definitely unindicated use of any of the instrument is not acceptable. We have to be taken consent and then only apply. And if patient is ready to push, if there is nothing, no fetal distress or no other means big of the caput formation or anything, obstruction sign is not there, you try to see. Yes, definitely one thing is, which is very practically used, that is of the fundal pressure. To avoid this fundal pressure, yes, the ventouse is very good instrument to use there. Because sometimes you have to assist the patient, give the fundal. So to just cut down this fundal pressure in your practice, you start using, you get a training with the ventouse instrument, and then you apply your ventouse. If in safe end, the ventouse is not of any harm to the patients in these cases. So this study that they have perinatal loss, there was a nil. It's not necessary that in the control there will be, but in this study they have found that only the one perinatal loss was there. If you see the time duration, yes, definitely you have curtailed the time duration in these patients. So program labor, that's why we call the alternative name is program labor. Means you have started since in the morning, the patient has labor pain and she has come, and then you have started their active management, and that to be finished within a time. So any of the emergency that can be managed by your routine staff, you are not needing any call for the other staff in the emergency and these patients. So again, in these rate of cervical dilatation in active phase, in the cases that 1.72 centimeters per hour, when the control it was 1.23 patients, so cervical dilatation is significantly faster in cases of these patients. Stages of labor, yes, active phase 3.45 hours, that was 4.78 hours. Second stage was 27.4 minutes in cases there. It was a 34 minutes. But now, a new criteria that if they are saying, yes, in cases of third stage, 4.46 and 4.45, this was not there. So everyone, whether you are going with the spontaneous labor, that is the normal patient, the active management of third stage of labor is the most important part, which everyone is practicing. But yes, active management of first and second stage, that also gives. So in these cases, in second stage now, as per the recent criteria, even the 2 hours has been taken, provided the fetal condition and maternal condition is not. So you are not in hurry to do the cesarean. If there is a slow progress, fetal heart is actually normal, even in the primary cases, up to 1 hour or 1.5 hours. But usually we are waiting for 1 hour, more than that. Everyone get the obstetrician distress occurs. So that's why always they go fast. The literature says that you can wait for 2 hours if the fetal condition and maternal both conditions are normal. Yes, pain relief was much better in the study group as compared to control, because during the control only we give just few of the medications. Sometimes if you are giving the late medication, then there will be not of a much of effect. If you are planned in the initial phase, then definitely the pain relief will be more. Yes, if you are giving any drugs, some of the side effects like nausea, vomiting, that again you have to give other. Yes, drowsiness is because we are giving diazepam and all sometimes. But with this dose of diazepam, there is no fetal respiratory depression has been seen in the various studies. If you properly monitor, yes, ruptured uterus, if in a monitored case, whether you are giving a medication, not giving a medication, that is never acceptable. So all obstetric units, they are taking care of that. Even any sign of the threatened rupture occurs, always you take the patient for the cesarean section. So the rate of cervical dilatation was slightly faster than, as if you see the p-value, it was a significantly good. Then duration of active phase of labor was significantly reduced. Then second stage of labor was again reduced in cases of active management. Majority of patients in the both groups delivered vaginally. And these 86% patients in study group has pain relief as compared to the 22% control group. And again, this is a significant result in that. This has significantly more drug-related side effects like nausea, vomiting, drowsiness that subsides after the 12 hours. So if they are taking one benefit, then slightly discomfort they have to face. And again, that there was no fetal and neonatal complications in groups they have formed. So antispasmodic reduces the duration of the first stage of labor by an average of 74.34 minutes. So mean was again, so it gives a 95% confidence interval in these patients. So these various studies, 13 studies has been done and they found this result. Again, these are the antispasmodic versus control. If you are giving antispasmodic, the mean duration of first stage of labor in the in this group was lower as compared to the in control group. So definitely we all know that helps into the cervical dilatation, that helps into the cervical softening. So this rate of cervical dilatation is increased when we are giving the antispasmodic drugs. So the mean rate of the cervical dilatation in the intervention group was 0.61% higher as compared to the not giving any antispasmodic. Duration, again, we have seen that there was a slight decrease in that. So what are the evidences on the epidocin? Epidocin, it's not a new drug. It has been used long back since our residency. Before that, I joined my residency in 1985. 84 and since then and before that, because all of our senior taught us how to give this. So this is the drug. I think any of the company men can be said that this drug was since which year this drug has been used in this. And this is the only drug which is used only in the liver. No, anywhere I haven't seen that. Yes, definitely it is in an anticholinergic drug. So muscarine receptor antagonist. All these are drugs. So this has been used long back. This is used as anticholinergic smooth muscle relaxant is the Hasian dilatation of the cervix when the same is delayed during the labor and is a visceral antispasmodic. Dose is 80 milligram IM, 10 milligram oral repeated as required. And epidocin, we have set our different protocols. We said that give one at around the 6 centimeters. If cervix sometimes you feel the ring is there, it is not stretching, because once you do the stretching, if it is going on, or sometimes the thick cervix, it is soft, but it is thick, or sometimes the form we have given one IM, one IV, but you always take caution that it is an anticholinergic drug. So side effects you have to say. So there are various comparison of the injection, rotavirine injection and velethamide bromide on the duration of the course of the labor. But this rotavirine has come into action for the very late. Initially, it was only the drug which you have seen. So rotavirine and velethamide, this drug, the mean duration of the active phase of the first stage of labor was significantly shorter in the rotavirine and the velethamide bromide group as compared to the control group, both in primary and multiparas. So the rate of cervical dilatation under the influence of the velethamide bromide and rotavirine is significantly higher as compared to the control group. So in each group, the dilatation was faster in multi-gravida patient as compared to the primary gravida, and was faster in the rotavirine group. So this effect of these are the various studies, and a single dose of 16 milligram velethamide bromide was administered via the intravenous route in the randomly selected 35 nulliparas and 37 multiparas, and the median time for the complete cervical dilatation to the delivery was 20 minutes in the group received velethamide bromide and 25 minutes in the group that did not receive velethamide bromide. So it is not in every patient, yes, indicated you give very good results has been found. So the median time for the complete cervical dilatation to delivery was 20 minutes in a group received velethamide bromide and 25 minutes in group that did not receive. So the velethamide bromide significantly shortens the second stage of the labor in the nulliparous patient, because these are the patients when they ask for the repeated PV examination. If you say no, there is a no dilatation, no increase, that always the family and everyone that now this time, not previously. Previously they used to ask that no doctor, you tried, but now every patient wants a very fast delivery, and they want if you are giving something, there should be some results. So this, and again, that any of the drug is not free of the side effects. The side effects not statistically significant in the velethamide versus the placebo group. So some side effects with the drugs, it is always found in these cases, and Q value was not. And one thing is there, if you are giving velethamide or not giving that, if the cervical dilatation occurs, usually patient feels nausea and vomiting. So we always that counsel our patient that you will feel this nausea and vomiting once the cervical dilatation starts. So in these cases, because neurogenic all practice that affects. Then again, study with the hyoscine and velethamide that has been given. So no statistical significance was found when ADR was compared between the age group of 18 to 25 and 26 to 35 years. Therefore, ADR reported that irrespective of the age of the patient and no life-threatening or the severe form of ADR, we are with the hyoscine and velethamide during the cervical dilatations. So in this study, they have included 130 pregnant women with the labor ward, and the data were taken from the patient receiving either the Buscopan or the velethamide, that is the epidocin. So the age is not affected by these. Again, the study with the dotaverine and velethamide, almost the same, but that we have to see that what is the side effect associated with this. So what are the advantages? That it shortens that, but not more than that. Shortening is we can have, yes, you can plan in a good way that by that time we can deliver our patients. So everything can be taken in when the full staff is available. Significant amnesia of the painful event of the labor because of that ketamine and all that amnesia occurs. Average blood loss was less. The duration of all the 3 stages of labor was markedly reduced, and obstetric management can be simplified, lowering the incidence of the operating. Yes, that is very important because now everywhere we have to, initially we used to call it as reduce resistance, reduce section. So it is not possible because of the so many, even the social factors are associated. So now we are talking about that optimize the cesarean section rate. So if you go with that, counsel your patient and proceed with this all protocols of that active management, we can optimize our cesarean rates. So neonatal morbidity, which is very important, was similar into the control group. So there is no extra harm while we are managing our patients with this labor protocols. So that counseling is also given that these drugs are not harming or not any way it is affecting our patients. So thank you very much for patient hearing.
Thank you, ma'am. It was nicely you have covered many aspects, many scientific aspects on active management of labor, partogram, and evidence-based studies, as well as the medication protocols. So many things have covered. And ma'am, in our comment section also, we have around 4-6 questions. So in that, out of that, so I'll take few. Dr. Bhargavi from Hyderabad. She is asking about is cocktail helpful in this scenario of mix? I think she is referring to the mixing of 2 or 3 drugs.
Yes, Dr. Bhargavi. Very nicely said. Yes,
Bhargavi
has been used. Yes, this was used in early 2000, means 2003, 4, 5, 6, up to 2010. We were very much because the ketamine was the new drug which has come. Nowadays, yes, everyone has made their own protocol. Initially, they give some that I'm saying that I don't know why the epidocin was out of market or there was some shortage or something as the dotaverine came into the market. So we have used the multiple doses of epidocin, that is there, and dotaverine we use in the restricted way. And sometimes some sedative, because sedatives we always avoided. So this cocktail, because I have tried these in our medical college, we have used these drugs. Yes, one point which I have mentioned, that there was no respiratory distress found into any of the fetus. So it is in a very low dose we are giving. But one thing I in throughout this presentation, I mentioned that how to optimize our cesarean section rate. Some patients are very anxious. They don't want to bear any pain. I mean, sometimes we call it as that we are sitting all together and saying, my cesarean rate is 80%. What to do that? Indication for the cesarean, the labor pain starts, patient starts saying, no, I can't bear labor pains, I can't. You do the PV examination, she is in the 7-8 centimeters. Sometimes they are not ready to push. Then we have to do something. Yes, this drug has been tried. Some patients, some are not still agree that we give this cocktail, but there is the various studies that prove there is no harm. We can use and we can counsel our patient in this way that we are giving all these drugs. You will have less pain. You will means your progress has been somehow accelerated. That can be used. Means if you think of that, because we have all NGOs, all government sector, they are saying that itna cesarean rate kyun hai? You have to reduce, you have to reduce. How to reduce? You must be knowing that you are also scared, your patients are scared, your patient relative. What they say? Hame normal delivery. What happens? They say, we want a normal delivery. Normal means vaginal delivery. But there should not be any negative part on that. Bachcha theek chahiye, mother theek chahiye. And if fetal are depths or some CTG gadbadaya, and we always take that, we explain, and they say that you take this is that. So, and some best part for this cocktail is useful in a very anxious patients. That you can try and you will get results out of that.
Okay.
I have any, you can just, you just give it that chance to speak also. I would like to listen.
No, actually, that's on the webinar mode. So surely we'll make it for the next time with a very interactive session, ma'am, so that we can do. And there is one more by Dr. Sharath. There is no question actually. Dr. Sharath is saying there is a clear-cut evidences which shows that how valethomate bromide is scores over drotaverine. Thank you. So they maybe because of the clinical study which you have shown. So because of that, they have given the compliments on this studies. And there is one more question. I think this would be the last by Dr. Supriya. Is there any standardization on the dosage part?
If you at least say there is no standardization whether it in any of the textbooks, but yes, with the experience and evidence, because these studies have been published. So these are the drugs. Yes, the doses you can do up and down, because we have made a 10 ml solution. Out of that, we are giving every dose that is of the 2 milligram of our diazepam. So that you can reduce it, that the patient may not require another dose. Or sometimes we have seen that some patients progress very fast. Even in primary, it is a 5 or 6 hours of the labor is there only. Then there is then the doses are required as less. Even a 1 epidosine injection that gives a very good result. Means in 6 centimeters you have given and you are coming after 1 hour, it is around the 8 or 9 centimeters there.
Okay. Thank you, ma'am. I think so. There are few just there was like thumbs up marks. So otherwise, these are the main 3 questions which I have taken. And really, it was like the informative session. Although you have shared the data, which will surely helpful for all the doctors who have joined here. And we are eagerly waiting for the clinical studies data or real clinical data, which you can share in our subsequent webinars, in upcoming webinars, ma'am.
Okay, thank you.
Thanks a lot, ma'am. And thank you, everyone, those who have joined. And we can surely get in touch with the, if any further queries, so we can surely get in touch. And you can post your comments in comment section, you can post your queries. So we'll surely get it addressed by Dr. Leela West, ma'am. Thank you, everyone.
Thank you.
Have a nice evening.
Oh, thank you.
Thank you.